Here we have a question for Andrew, actually. When you were speaking, Andrew, you gave an example of step therapy requiring an off-label use for a medication, and the thought was, or the question was, could you expand on that? Interestingly, the Maryland law that was passed bans that procedure. The requirement of an off-label or a non-FDA use in a step therapy protocol is banned under the Maryland law. And frankly, I personally think it's pretty offensive that something that a pharmaceutical company would end up getting in a lot of trouble if they were selling something for that they're not allowed to do, but the drug company can do it. But Andrew, let's hear your thoughts on that.
Yeah, that's a complex issue because there are, for example, in the case of bipolar disorder, there aren't a lot of on-label indications for many of these medications. Bipolar disorder is a very complex condition with mania and depression and even psychosis. And so some of the prescribing that's done for serious mental illness is often done off-label, but just because it's off-label doesn't mean it's not clinically sound, because we have clinical treatment guidelines published by specialty societies that often entail off-label prescribing. So it's not always a bad idea, but in many cases it is going to be very dangerous, and quite frankly that probably is a patient safety issue in terms of in many cases banning a step therapy requirement with an off-label use, and it can be quite dangerous, but we want to make sure that clinicians are following sound, peer-reviewed, scientifically evidence-based treatment guidelines. And I know that some of the other physicians there, in the case of dermatology or rheumatology, you might be able to illuminate that more in terms of making sure it's not just the label, but that the step therapy being, to the extent that it happens, we want to make sure that it's in line with evidence-based practice guidelines developed by specialist societies and based on sound research.
Yeah,
Okay,
well,
so
I mean, I'll take it a step further. This is a true story, but I've had patients stepped upon. That's sort of what I tend to call it. Where the insurance company is actually requiring that they step first onto a suboptimal dose of the medication. So, okay, physician and patient, you can have your first choice medication that you think will be most effective. But you have to first try a lower dose. Of course, that translates into a lower cost. So you can use the biologic drug that you think will be most effective for the patient's psoriasis, but you have to start out using a suboptimal dose. Some of the drugs that we prescribe, of course, are dosed based on the patient's weight. Larger people require more drugs. Smaller people will have a therapeutic effect on a lower dose of the drug. And I've seen policy that states that the patient has to first be tried on a dose lower than the optimal dose, and then if they fail that, which of course they ultimately will, then and only then, after several doses, and this can be a lag time of 6 months, can you actually prescribe the appropriate dose indicated based on clinical trials for their weight. So decisions are being made by people who don't deal with these diseases that influence how we treat the patient.